Hi, everyone. I'm Emily.
And this is Eva.
And you're listening to Speech Talk.
We're your research book club so you can do evidence-based practice in practice.
So let's start talking. Eva, how are you? Tell me all about it.
I was really hoping to ask you first because I feel like I can't think of anything that happened this week that was like work related. I'm like, I know I went to work. I did go. I clocked in and then, I did fit testing this week. Have you ever done fit testing?
Yeah, for your N95.
Yeah. And so if you don't know what this is, basically you're trying to find out, are you wearing your N95 appropriately? Like, is it actually preventing anything from getting in? And the way they test this is they have you put on the N95 appropriately. Then they put a large bag over your head and they spray an odorless but terrible tasting solution into the bag. And if you can taste it, then you fail. But in order to make sure you know what it tastes like, they have you inhale it through your mouth beforehand. And so I'm just standing there doing the testing as he's like counting off the segments, and we're all like bending over and turning our heads left and right to try and like loosen the mask to assess whether or not it's properly sealed. So it's just like a room of people nodding, shaking, bowing, only breathing through their mouths, and everyone faintly tasting this disgusting acrid
With bags
flavor.
on your head.
With bags on our heads. I was like, this is super weird if you're watching from the window.
I know. We did that too, except your company is mean. There's a sweet flavored one. Why are they making you do the bitter one? My company actually said, like, there's a sweet one and a bitter one, but we wouldn't do that to you.
Boo. I didn't know there was an option.
I remember when I did that too, they had us doing like all these like physical exertion things. And I was like, can I not do the jumping jacks? It makes me pee my pants. Like Leighton's having baby
3 kids
problems.
later, my pelvic floor is not what it once was.
That's funny.
Okay. And how about you, Emily? What you been up to?
I got back from vacation, so I still feel like I'm on vacation and I just don't care to be at work. So I'm just like, have been going through the motions. I called one of our mutual friends and I was like, girl, it just sucks. It just sucks. And she goes, you know what? Sometimes when I feel like that, it's because I've lost creativity. And I was like, shut up, you're right. But like, it's a hard realization when you're like, yeah, this is an introspective problem.
Okay. And before we start this week's episode, we're trying something new. Here are some quick headlines from the SLP research world. 1. Dysphagia may now be the primary indicator of malnutrition in head and neck cancer from the Oral Oncology Report. Also, being able to measure a patient's circumlocution may help as a diagnostic factor for very mild aphasia, also known as VMA, as if we need another acronym to learn. And finally, a study published in Digital Signal Processing discussed how a new AI approach helped computers more accurately recognize people with dysarthria, which is so helpful. I mean, think about all the times we use like voice authentication for our phones or our bank accounts, and people with dysarthria really struggle with things like that. So way to go, folks. Way to keep researching.
Yeah, well, sounds like one of those, at least one of those could be an episode.
Yeah, seriously. We'll circle back to one of those. All right, Emily, get us started. What are we doing?
So this week, Eva, when you hear someone say trach patient, what is the first thing that comes to your mind clinically?
Like, oh God. Oh God, no. I'm so sorry if you or a loved one has a trach. I just, as a clinician who has genuinely not had a lot of opportunities to do trach work, and I know that this is a medically very fragile population, I'm like, oh no, somebody hold my hand. I need more guidance is my overall emotional reaction. And then I remember random words like cuff and deflate and cannula. And that's about it.
Those are all very awesome words.
I did go to school. I know some words.
when it comes to trachs, I think you did hit a lot of what makes people very nervous. And I think the major or one of the most prevalent being that you're just medically fragile when you have a trach. So I keep saying that word trach. What is a trach? A tracheostomy is a tube that connects your airway or moves your airway from your mouth and nose to a hole in your neck. And that's significant because there's not typically a hole in your neck. And that makes a lot of things that we deal with as speech therapists difficult, like eating and talking.
Yeah. And specifically, that hole goes like into your airway. So we have this additional orifice to your airway, which, by the way, you got to figure out how to keep stuff out of it, because things are not supposed to be getting into your lungs. And then also on the back end, when you're swallowing, now we have this other like complicating factor of, well, there's more than one way in and out these days.
Yes. And this is one of the more technical areas for us speech therapists. Whether you're dealing with this for adults or children, these patients are pretty medically fragile and need a lot of extra care and attention. And we have to be on our P's and Q's when we're dealing with tracheostomy tubes and the patients who have them.
Yeah. And I'll say, thank gosh, not a ton of people need trachs. And that's why they are such a small subset of our clinical caseload. But the result is that it's really hard to get exposure and like good clinical training. So yeah, I do think that there's a lot of reasons that relatively new clinicians or clinicians who just haven't had a lot of opportunities for them to be nervous.
Right. And a lot of times, if someone does have a trach, they are going to a specialized facility that houses many people who have trachs, and they have respiratory therapists on staff. And not all skilled nursing homes offer this. So I have talked about my previous experience with trachs, but I wanted to just go a little bit further into our role in the tracheostomy care this week.
All right, BRB, you guys, we're going to check some cuff pressures and dream of sponsorships.
When you need to build up your team to handle the growing chaos at work, use Indeed Sponsored Jobs. It gives your job post the boost it needs to be seen and helps reach people with the right skills, certifications, and more. Spend less time searching and more time actually interviewing candidates who check all your boxes. Listeners of this show will get a $75 sponsored job credit at Indeed.com/podcast. That's Indeed.com/podcast. Terms and conditions apply. Need a hiring hero? This is a job for Indeed Sponsored Jobs.
Get business done with the new American Express Graphite Business Cash Unlimited card. With unlimited 2% cash back on all eligible purchases, unlimited 5% cash back on flights and prepaid hotels booked through American Express Travel Online, and a flexible spending capacity that can grow with your business, you'll have the confidence to keep building. Apply today and earn a welcome offer of $1,500 cash back after you spend $50,000 in qualifying purchases on your new card within the first 6 months of card membership. Terms apply. Learn more at go.amex/graphite.
So the research this week, we're discussing speech pathology services are integral but underutilized in tracheostomy rehabilitation by Stephanie Davis, Ashley Way, Salem O. Salomon, and all.
Yeah, so their basic premise was that SLPs are underutilized in tracheostomy care, despite the fact that we are really valuable. We do a lot of respiratory work, we do feeding work, we do communication work, which are all affected with a tracheostomy. So they reviewed about 255 tracheostomy patients and found that 23% never received an SLP evaluation. Only about 34% got a speaking valve and about 53% got a swallow study. Patients who did receive SLP services had consistently better decannulation rates, and the authors recommend earlier routine SLP involvement. All that is to say is, like, before we really get into the nitty gritty, if I didn't already enough, is that the authors are basically like, look, if we can get earlier routine SLP involvement, that would be great, and create a clinical workflow to standardize that pathway the pathway specifically from tracheostomy to decannulation.
They cited that over 100,000 patients receive a tracheostomy each year, and those people receiving tracheostomy are because of prolonged mechanical ventilation, trauma, and upper airway obstruction.
Yeah, which I think just jumps back to what we were saying earlier about fragile populations. Like if you have a tracheostomy, something intense happened. Like this is not the only thing going on.
The study in general, it was a retrospective study, which means they were digging through all of these old charts to find information so that we already know that there can be errors and limitations. So we're just going to keep this mindful while we're going through this. They're just going through old notes. They couldn't change or fix anything. They were just looking at what had happened.
Admittedly, I love a retrospective study. I think that there is so much to be done with just the documents we already have. And congrats to people who are working on like clinical intervention research, but there's so much documentation about like how patients were treated, what their plans of care were. And it's just like this, I don't know, I'm like, it's like an orchard of like research material
And
to start picking charts off of trees.
it makes you feel better that like maybe someday somebody will actually read your notes.
That would be incredible. And some of those are embarrassing. I
I was tired that day.
yeah, some days I go back, I read my notes, I'm like, wow, that is not my best clinical writing.
So one of the things they wanted to see was 100% SLP evaluation after tracheostomy. But where did they actually land? At about 77%. With the SLP getting the call like 6 to 8 days post-op.
That like first period, the 6 to 7 days after post-op is kind of mind-boggling to me because in my mind, I'm thinking about all the patients I get who have been intubated, like they had something traumatic happen and they had to, force the airway. And I'm like, those people are put NPO. Like, I don't know. I guess part of maybe my shock is that I don't actually know what the transition to, getting put back on food is after you have a tracheostomy. But I'm just imagining people being on an NPO diet for like 6 to 8 days. And maybe that's not accurate. But I'm just like, oh, wow, no one's doing like a swallow study after they put in the trach for like a week? That's crazy.
And I will say that like that was surprising to me too. Normally when I see somebody who has a trach, that is one of the first thing that I'm looking for, but they do. A lot of the patients who come to the skilled nursing, they have a peg tube. Like they'll in the hospital, they're medically fragile. Maybe they get an NG tube for the short term, but as they stay on the NG tube, that doesn't last very long. And then they'll get the peg tube in the meantime. But even so,
Mhm.
NPO, your oral cavity quickly dries up. You'll be surprised how many like thick like boogers I've pulled off of the
Oh,
inside of
God.
people's mouths because
Oh.
they got put on NPO and just forgotten about. And that is
Mm,
terrible. It's always like the
yeah,
worst thing to see.
yeah, that is really terrible. And I think one of the difficult things for us, like tell me from your experience, when you're getting people who are trached and they have a peg tube, did they have a swallow study done when they came to you? Like, did they have one in their chart?
It's a lot of times it depends on the person or the circumstances, how alert somebody is. I've gotten people who, when I'm evaluating, I'm using the Glasgow Coma Scale, right, to see if they're even responsive to me, if they're able
Mm,
to respond to cues or anything like that, all the way to somebody who is very fluently having conversations with me. But I will say,
yeah.
even though that is the spectrum of people that I've seen at evaluation, it's also been a spectrum of people who have had swallow studies done. I think it's, in my experience, it's been very quick that if somebody has a trach, then next they're NPO for a few days, they got to have a peg tube. And
Hmm.
um, I don't know, for me, I've never recommended anyone having a peg tube in my career. But I'm sure a lot of acute care SLPs are very comfortable, like NPO, got to get a peg, and it's easy. But that area kind of scares me. So that was surprising to
Yeah.
me too, that 6 to 8 days. It was funny in that article too, they said that the least likely group to get an SLP eval was the upper airway obstruction, which was ironically funny to me because that's like our whole niche is like the upper
Upper
airway.
airway.
So like if they like choked or something, if something happened to their pharynx that required them to have tracheostomy, then they're like, nah, we don't need those speech therapists. What would they know?
You know what? That's a really good point. I didn't think about that at all. That like the potential like subdemographic that we would be most relevant towards are like, no, I'm least likely to get an SLP eval. I wonder why.
It's retrospective. We'll never know.
We'll never know. We can never go ask those people.
About 33 of the population evaluated was cleared for a speaking valve, and then about half of the subjects had a swallow eval, and 75% of the swallow evals performed were bedside. Eva.
What? Wait. 3/4 of the swallow evals were only bedside swallows? Okay. If you don't know what that means, it's the so an instrumental swallow study is where they actually have you eat either with in front of a X-ray machine or with a camera looking into your throat. So you were actually seeing the swallow. A bedside is where we just give you some food and we watch you and we listen to you and we're like, I think it's fine. And the idea that 3/4 of the subjects were given an I think it's fine style evaluation when they had a tracheostomy blows my mind.
It is highly surprising because the biggest thing about tracheostomies when it comes to those swallow evals is that with the opening of your neck with that airway, you're not getting air from your mouth and your nose down into your lungs. You're missing a big sensory component when it comes to swallowing, and you're not feeling things the same way. You're not tasting things the same way. And you don't have that pressure differential that a normal healthy swallow has when all of the tubes and pumps and areas are closed like they should be.
Sorry, I'm just imagining like an anatomy and physiology class, and they're like, okay, this picture of someone's respiratory tract, tubes and pumps, you guys. Just tubes and pumps. That's it.
That'll be the next meme is tubes and pumps.
This is the large tube. This is the small tube, the big pump, the medium-sized pump. You guys are going to do fine.
There's like all of these systems working together. So when there's something that creates that opening that ruins that pumping and closed system, what we see is a whole lot of silent aspiration that people are aspirating and we don't see it. So if we're only doing bedside evaluations for people who have an already pretty compromised airway, that's bad. That's bad. I don't.
That's pretty bad.
I don't condone. But retrospective,
No, we're just sitting here.
We're just looking back.
We're just sitting here looking at the papers and being like, who made what decisions?
We look back at it so we can make better decisions in the future.
Knowing history, man, don't repeat it. So a majority of the subjects were eventually decannulated, 62%, during the follow-up period. SLB services were utilized more in subjects with a longer duration of tracheostomy dependence, and there was consistent improvement in downsize and decannulation rates in like all of the cohorts, so all of the groups. So what are some of those terms? Well, tracheostomy dependence is like were you reliant on the tracheostomy for a while, and then the downsize and decannulation. So decannulation is when we are able to take out that tube from your throat. Is that right, Emily? Did I get that right? Okay. In our super technical language that we're using here today, that tube in the hole in your airway that was made by a surgeon and not by God, that we took it out.
So what makes someone a bad versus a good candidate for decannulation?
Let me see. If I were to guess a bad candidate for decannulation, Oh, I was going to guess somebody who has bad cognition because we love to talk about the intersection with cognition. But I'm like, I don't know, maybe they're not a good candidate in the first place because if they like don't know what it's about, then maybe they're trying to take it out. So is it cognition?
Cognition was not listed, but I do like that. The two that they put down was having pneumonia and being unable to manage your secretions. So if you're getting mucus built up in your lungs, you're not able to
Mm,
cough that up through your mouth. You're needing suctioning through your tracheostoma hole that's in your neck. Tracheostomy is the contraption that's in your neck. On the flip side, what would make someone a good candidate for decannulation?
that they, I don't know, demonstrate like independent management or oh, wait, you said that they can't manage their secretion. So maybe these people have a good cough or like good secretion management.
Snaps for Eva. Yes. Adequate cough. They're able to clear those secretions. Another good positive indicator that their tracheostomy tube has been previously downsized. So maybe they started from a larger hole and they're healing. Tolerance of an occlusive cap. So that is where the tracheostomy is still present, but instead of breathing through the tracheostomy, having that open, they put like a cover on it. So then your airway is able to go back up through your nose and mouth, and that
Hmm.
cover is just acting like your skin would normally. And then finally,
Hmm.
maintenance of oxygen levels of 90% or more for 24 hours on room air. So we're not using any other types of devices to help you breathe.
Yeah. Just in general, PSA, if your oxygen is below 90, go get help right now. Stop listening to this podcast if you're like oxygenating below 90 and go seek medical attention. Thank you.
That's funny that you said 90 because it's like, well, I'll bring out my pulse ox and it's 80. If anybody's below 86, then you stop treating like that. So we got a little bit of wiggle room here.
I will say that on like the decannulation predictors, some other things that were higher odds of decannulation were like head and neck cancer, trauma, and successful swallow study. So like if those things are present, then you have higher odds. And lower odds of getting decannulation are obesity and prior tracheostomy history. Actually, the reason that head and neck cancer has a higher decannulation rate is because a lot of times the tracheostomy is actually elective. So they put it in beforehand, like as a preventative measure, kind of like sometimes they put in a peg tube before someone starts treatment so that they're kind of like already set up. We don't have to be potentially engaging in these things after they've undergone cancer treatment.
I wonder where that brings us back to the involvement of a speech therapist in those cases.
So the way I read it was that a lot of times these patients, they're decannulated way more quickly, like the 4 to 5 days. So they didn't really feel that SLP clinicians were necessarily urgent. I don't know that I necessarily agree with that because to me, I'm like, you still did an invasive procedure that changed someone's airway, albeit temporarily. You can't just guarantee that like it's gonna work 100%. Like all surgeries have like risk of complications. Every time you cut somebody open and put something in them and then take it back out, I think we should just cautiously be assessing the situation and hoping that it's fine and we don't need further intervention. But just like, why don't we do a video fluoroscopy study, just real quick?
Right. If they have the head and neck cancer diagnosis, then I'm sure it's not just that we could be evaluating and doing. So that
Yeah.
pulls back into, I guess, the underutilization of the speech therapist in the case. I'm assuming.
Yeah.
It's
Well,
retrospective.
and particularly because like when we think about those cancer patients, what they're saying is that the tracheostomy was preemptive, right? So we're just going to take it out. But again, these are head and neck cancer patients. They could have been having parts of their tongue removed, parts of their pharynx removed, like critical pieces of like muscle groups and organs that are related to eating and swallowing. So I think that the authors touched on this, that this is kind of a red flag that the lack of SLP was more related to, oh, this is like a cut and dry tracheostomy procedure, ignoring, on the other hand, the head and neck cancer aspect of it.
The other thing I thought they said in the article was interesting. So, frequent late or often missed consults to SLP were causing frequent delays in the rehabilitation and decannulation process. So, they said additionally, there were regular urgent consults placed to SLP and the surgical airway teams on the day of discharge
Oh my God.
to give evaluations and guidance about decannulation where rehabilitation potential is limited to time constraints.
I love that. They're like, really quick, before we send this patient home or to skilled nursing, there's like a critical airway problem. Can you just like jump down here and give us your advice?
It's so crazy because there's so many things that you want to look at when it comes to someone who has a tracheostomy. Are we looking at voice? Are we looking at swallowing? Like, what is the goals here?
Yeah.
And how can we help? Like that, the day of discharge, I would be livid. I would.
Look, man, the number of things that happen day of discharges will always blow my mind. But I think in terms of like other seemingly counterintuitive findings, they also said that patients who received speaking valves actually had longer tracheostomy durations, but higher decannulation rates. And this is maybe because SLPs were called in on these harder cases. So it's kind of like underselling the impact of SLPs in a way.
Yeah, definitely underselling. I think in some of those cases, maybe it takes the speaking, like the speaking valve may take longer. I mean, it's always dependent on the person, but maybe it takes longer because you're being cautious about how quickly you're upgrading these people. Every speech therapist is very different in their practice, and some speech therapists are like, yeah, you look good. We did this for 30 minutes. Now keep it on all waking hours, you know? And other people are like, let's do an hour, let's do 3. And that rehabilitation timeline could just be medical reasons, the speech therapist. But I mean, we'll honestly never know. But having someone there in case something goes wrong is always going to be better than nothing.
Yeah, definitely.
So, how do we apply the research? What should a skilled nursing SLP know when receiving a patient with a tracheostomy?
Well, definitely have they had a swallow study.
Yeah, review the chart.
Let's find that out. We want to know why they got trached because that is really informative in our plan of care development. Like head and neck cancer versus motor vehicle accident is going to be different in our approach.
You're exactly right. We need to know what happened in the situation to have someone on a tracheostomy tube. But when you're preparing to go into that evaluation, the things that I always look to want to know is I want to know the size of the trach. Is it like how big is the trach itself? I want to know what kind of air they're on. Are they on a mechanical ventilator? Are they on room air? Are they breathing through nasal cannula? What is the trach like? Is it like a constantly cupped trach? They have some that are like foam almost, that are a little bit more malleable. I want to know their diet. I want to know if they came on a peg tube or not.
Yeah. And I would also say, like, if we're trying to get, in terms of the overall plan of care development, if we're trying to get a sense of are they going to be ready for decannulation, we can refer to some of what we talked about earlier, like use that checklist that they came up with, which I think they said has like a 93% positive predictive value. So it's a pretty good checklist. Was the tube downsized, just like you said? Can they clear secretions with coughing? Can they tolerate that occlusive cap, that sort of lid on the tracheostomy? And are they saturating at 90% oxygen on room air for like 24 hours? So if when you're looking at your plan of care for your patient and they're saying, hey, can I do this? You can tell that to the doctor, be like, hey, they've met these 4 checklist items. I think it's time that we start looking at their overall plan of care in terms of decannulation.
Yeah, really good short-term goals for those. If you were receiving a patient with a tracheostomy, what might be some red flags that would make you push for an additional assessment?
Sorry, wait 1 second. It just occurred to me. Your initial question was, what should SNF SLPs know when receiving a patient with a trach? And my gut reaction was still like, everything. Where's my help? Like, mom, hold my hand. And I'm so sorry for if any of you thought that that's what this episode was going to be, and it wasn't. I'm really sorry. We weren't here to re-explain all of trach care to you. I I hope one day to be that competent of a clinician. Like, circle back in a year and we'll find out if I've improved at all.
Oh, you will.
I don't know. I don't get a lot of trach patients. It's still a great mystery to me.
Not the you're not getting a lot of trach patients at the hospital?
I have not had a single trach patient since I've been at the hospital.
Wild.
Wild. I know. Again, it's just crazy how different caseloads can be. But anyways, going back to your red flags that would make you push for an additional assessment, probably one that not being able to clear your own secretions. If they're not coughing stuff up, then we have some serious concerns about airway compromise overall.
So that actually probably wouldn't be a red flag to me because
No?
no, because with the airway being opened, if they're not clearing secretions, they just suction.
Oh, that's a really good point. That's a really good point. But I don't know. I think I still want to like see maybe an instrumental. No?
And if we're ready for food, if like that is the next thing.
Oh, I see what you're saying. Yeah. Okay. If we're working to get off of an NPO or like a no food order.
So if red flags, I might say if somebody is seemingly constantly fighting an infection, like I would want to see if something was going wrong with their airway. If for some reason they're using their passy mirror and they cannot voice, I would be curious to see about aphasia to see if there was any damage to their vocal folds.
Okay.
If we're starting to do food or starting to do liquids and you just notice a rush a rush of fluid coming from the trach, like that's a huge red flag. Like stop.
And how would you say that we can start, like as the article says, advocating for earlier SLP involvement for our trach patients?
I always feel like education is going to be where it's at. You might feel like you're blue in the face, but if you are with the doctors, if you're with your staff and you are showing them, look, these are the things that we are able to do. And you come with articles like these handy and say, we can be more involved in these cases. And if you are, God forbid, the SLP who is getting those trach referrals on day of discharge, take these articles and just mass print, put them all over whoever office it is who's not giving you the referrals and tell them that, you are valuable in the care of these patients and you deserve to have a voice and a spot and a seat at the table.
Yeah. And I think if I can kind of reflect what you're saying, it's not just that we should be involved, it's that we shouldn't just be the emergency call, like that discharge day consult. No, we should be there advising. And even if our advice is, nope, this patient is clear, like we don't need to be involved any further, great. But that's an important data point that that patient is safe. And we needed to have verified that. And because the answer could be the converse. The answer could be, wow, there is like some severe airway compromise, even with the tracheostomy, we're seeing some big issues with this person's management of their secretions. We want to be here helping them plan through that.
Yeah.
And also for the speaking valve. Aren't we the talking people? I don't understand.
I know. And it comes to the use of the speaking valve. I'm not sure, like I probably should have Googled this before the episode, but who is all qualified to be like handing them out? But
Mhm.
I mean, we're included in that list. So if it's just that people are going from trach to being capped because there's not that intermediary area where we would step in and give those devices or provide that education, that it's an opportunity missed.
Yeah. So get involved as early as possible. Understand the decannulation workflow and like what that checklist is, and really make an effort to be a part of the team because your insight is valuable, even if it means going back to your textbooks and rereading everything you used to know about trachs. I promise you can still be helpful.
And if you really don't know where to start, Passy Mir has really great free CEUs for you to watch and get refreshers.
Can I do that like right now?
All right, guys. When in doubt, dig into the research. We'll be here for you when you do.
More evidence, more questions feels accurate at this point for me today.
You've been listening to Speech Talk.
Thank you, everyone, for coming to listen to our Research Book Club. Until next time, keep learning and leading with research.
If you like this episode and you want to give us some love, please rate us on your favorite podcasting app. Leave a review and tell the world, because as podcasters, our love language is in positive affirmations.
And if you like listening to us, you may like more podcasts from our network, Human Content, like How to Be Patient, Bendy Bodies, Knock Knock High with the Glockenfleckens, and Psychiatry Bootcamp.
If you have a research topic you want us to cover, or you have episode comments, clinical experience you want to share, or just want to send us some love letters, send us an email at hello@speechtalkpod.com.
If you want even more Speech Talk content, check out our website at speechtalkpod.com, where you can find all of our resources we made for you, copies of articles covered, and Eva's blog following these topics and more.
We're your hosts, Eva Johnson and Emily Brady.
Our editor and engineer is Andrew Sims.
Our music is by Omar Ben-Zvi.
Our executive producers are Aaron Corney, Rob Goldman, and Shanti Brook.
To learn about Speech Talk's program disclaimer and ethics policy, verification and licensing terms, and HIPAA release terms, you can go to speechtalkpod.com/disclaimers.
Speech Talk is a proud member of the Human Content Podcast Network.
NFL football season is here, which means when you switch to Verizon, it feels like touchdown, because you get NFL Sunday Ticket from YouTube on us when you buy an eligible 5G phone on select unlimited plans, which means you can watch every out-of-market game every Sunday afternoon, and it's all on us. Now that's the Verizon way to kick off the NFL football season right. Switch and get NFL Sunday Ticket from YouTube on us, only with Verizon.
Avatar: Fire and Ash is now streaming on Disney+. It's the film critics are calling the best Avatar yet.
Go, 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 go!
A true epic and completely jaw-dropping.
This is the only pure thing in this world.
Return to Pandora on Disney+.
It will be an adventure for the whole fam.
And watch the Oscar-winning phenomenon at home.
This is sick!
Avatar: Fire and Ash, now streaming on Disney+. Rated PG-13.